selection is often guided by 3 pain descriptions: pain generator, duration, severity. Okay, what are examples of generators of pain? Nociception, neuropathic, psychogenic. Okay, what's the other type that we never want to get? Cancer, malignancy. Okay. Types of severity, thinking of mild, moderate, severe, 0 to 10. Duration, we have acute, subacute, and chronic. The analgesic ladder is a systematic approach for managing what type of pain? Cancer-related pain. And it is solely based on which of those pain types. The severity, correct. All right, moving on to herbals and supplements. Juniors, I'm going to turn to you guys. We're going to do a raise of hands, either true or false. So some herbals and supplements have FDA-approved indications for painful conditions, such as osteoarthritis, peripheral neuropathies, and migraines. Show of hands for true. Show of hands for false. Okay, so sophomores, tell me why the juniors are saying false. There's no FDA approval for these. Perfect. Could they be helpful in those conditions? Potentially, yes. Okay. All right, juniors, same thing. Second one here. Some herbals and supplements carry risks such as increased risk of bleeding, hepatotoxicity, or opioid overdose. Who says true? Who says false? Perfect. Yeah, so this one's going to be true. Certainly some carry, I would say bleeding risk is the most common of most of the herbal products. Some of them have hepatotoxicity, and then which one has an opioid overdose risk? Kratom. Perfect. All right, memory joggers for topicals and NSAIDs. So sophomores, systemic absorption may increase. Okay, so you put it on your skin, we want it to be topical, but now it becomes transdermal and it's going into your skin, going into that bloodstream. Sites that have good or bad skin integrity is going to increase that risk of absorption. Bad skin integrity, so things like abrasions, wounds, cuts, if you put it on that skin is not intact, you're going to get more of that blood flow getting to that area there. And then I kind of just gave away the next one. So blood flow, the more blood flow that we have to the area, the more likely that it's going to get into that blood flow for systemic absorption. All right, the next one. Which topicals have neck warming effects? Capsaicin. We remember the mnemonic. Good. What's the other C? Camphor. Good. So we remember that by the ones that are caliente are going to be our warming ones. All right, lidocaine patches should not exceed what dosing approach? 3 patches per 12 hours. Good. All right, juniors. Your answers are either 1 or 2 for these next 2. So agents that are more COX-blank inhibition have greater cardiovascular risk. So who says 1? Who says 2? Perfect, yeah. So our more COX-2 selectives, which are going to be things like celecoxib or meloxicam, diclofenac, and piroxicam, are going to have theoretical heightened cardiovascular risks. And then that means that those that are more COX-1 selective are going to have that increased bleeding risk. All right. Anti-inflammatory effects occur at low, moderate, or high doses of NSAIDs. High doses. Good. What happens at low? Platelets. Okay, so remember baby aspirin. We're going to have platelet effects at low doses. Moderate doses is where we get that pain perception change. Okay. And then true or false, salicylate toxicity presentation usually involves respiratory alkalosis and metabolic acidosis. Juniors, we're going to go with true. False. Not a lot of takers. Sophomores, true. False. We're all saying true, yes. So this one is true. All right. right, we're going to go back into our slides. We are around, on the PDF, around page 82, I believe. And we picked up with little Jackson, who decided that he loves that orange flavor that baby aspirin is. And so he actually ate all 30 remaining tablets of his grandmother's. They're that good. They're really small, they're chewable, they don't taste bad at all. Loves it. Little chalky, it's fine. Okay, so maybe we're worried that he could have had an overdose, right? We can calculate it, right? So we would first call poison control. Poison control would do the math. They would say, yes, 30 tablets was the exact cutoff that he likely has overdosed. Okay, so we're worried about toxicity. There's a couple ways that we can help manage that. Is there an antidote to aspirin overdose? Is it an antidote? No. So it won't reverse it. It will help manage the symptoms. Okay, so things like sodium bicarb, we can do oxygen, electrolyte, sugars. We can try to do activated charcoal, and then worst case, what could we do? Dialysis. Okay. What else might we be worried about in a kiddo that has aspirin? Bleeding, but Reye syndrome. What is another factor that is involved in Reye syndrome if someone gets it? What else should they probably have as well? Some sort of viral illness is usually when we see it. Okay, so if Jackson wasn't feeling too good, had a little stuffy nose, coughing a little bit, maybe that would make us think other concerns as well. All right. A few more NSAIDs here, and then we'll wrap up this section. So ibuprofen, by far our most common NSAID here in the U.S. Usually we go by ibuprofen or Advil or Motrin. How I remember these versus naproxen is that Advil and Motrin both have I's in their brand name, where Aleve for naproxen does not have an I. Okay, so that's just a helpful one for me. Ibuprofen is acidic, so it's also going to have that topical irritation when we ingest it. This one does have dosing that I do expect you guys to know for the sake of we don't want to kill anyone. Okay, so there's very few doses that I expect you to know, mainly being ibuprofen here. So the pediatric dose is going to be 5 to 10 mg per kg per dose, and we're going to do it every 6 to 8 hours. So if we had little baby Oliver, he's our 8-month-old infant, he has known influenza A, he has general discomfort, is fevering, and clinical course is as expected. We don't anticipate any sort of hospitalization at this point for him. Theoretically, could we calculate what dose of ibuprofen for him? Yes, beautiful. Okay. Celebrex or celecoxib is another one. So this is going to be one of our most COX-2 selective. So it has the theoretical GI protection risk, and therefore also that theoretical cardiovascular event risk. However, studies have shown that even at modest dosing, so what we want for that pain perception, it's no worse than ibuprofen or naproxen. Okay? Celebrex does contain a sulfa group. You will get these alerts when you order it. If someone has a sulfa allergy, it'll say, you really want to order this? And the horrible thing is that those alerts shouldn't exist because it is completely okay to give Celebrex to someone that has a sulfa allergy. It is not the same type of sulfa group. Some patients, usually older patients, may have concerns with different NSAIDs because they've been around, they've seen the news. Back in the early 2000s, 2004, 2005, there was Vivox, which was a very COX-2 selective. It was actually FDA mandatory to be withdrawn off the market due to the fact that it was so COX-2 selective that all these people were getting MIs. So that one was about 300 times more selective to COX-2. Current COX-2 selective agents are about 30 times. Okay, so extremely different. I probably have 1 or 2 patients a year that can recall that and, oh, I don't want to take that, right? That's going to give me a heart attack. I doubt it, but let's talk about it, okay? So this slide is kind of a summary of some of the key points with each of the NSAIDs. We see our COX selectivity there, that range, and then some of those key points. We didn't specifically talk about indomethacin, but that one has a unique side effect of some CNS confusion, hallucination type things as well. Clinical pros with NSAIDs, so there is no one-size-fits-all specific NSAID that we need to choose. We always want to make sure that we're using the lowest dose for the indication that we need. So patients who come to me, ibuprofen 800 4 times a day, not my favorite, right? Like you have chronic pain and all you need is that pain perception change and not that constant bleeding risk and constant inflammation risk. It's a lot of education for those folks. Making sure that we're thinking about different risk factors and side effects when thinking about our NSAID dosing duration and considering any protective agents. What things might we add to NSAID therapy for protection? What are we trying to protect? Your GI, okay? And what 2 drug classes could we use? PPIs. What's the other one? Misoprostol, okay? So specifically just replacing those prostaglandins. And then if one NSAID is ineffective, we can consider doing any sort of dose adjustment or rotating to another NSAID. So even if someone has not found benefit with 1 or 2 NSAIDs, there's still likelihood that they'll find benefit with others, similar to most antidepressants. All right, any questions with NSAIDs? Okay. All right, we'll move on to acetaminophen or APAP. Paracetamol is going to be the European name for it, so most of our studies are from Europe, so we'll see studies with that. It's going to be known as Tylenol for our oral. There is an IV formulation as well, but it is fairly costly. Mechanistically, we're going to have an indirect inhibition of prostaglandins, so we're not acting on the prostaglandins necessarily themselves, and we're only really focusing in the CNS. Okay, so NSAIDs are nice because they work in the CNS and the periphery. Tylenol really only works in the CNS. So our net effect is we're going to have that analgesic effect, that antipyretic effect in the CNS, and very minimal systemic anti-inflammatory and antiplatelet effects. Okay, this is good and bad depending on our patient and what their needs are. Our uses are going to be self-limited painful conditions, mild to moderate non-inflammatory pain conditions, and then any sort of analgesic or antipyretic effects during an illness. Comes in a whole variety of preparations. Our standard dosing is going to be 500 to 1,000 every 4 to 6, not to exceed the maximum of 4,000 a day, or 4 grams. And that is if you are choosing as their provider to monitor them, okay? If you're like, I don't really want to monitor how effective and how safe this is for you, that maximum is going to be 3,000. And then if they have any sort of hepatic concerns, the maximum is going to be 2,000. This is another pediatric dosing that I expect you to know. And then you can see the similarity with ibuprofen. So if you only had to remember a dosing, what is the milligrams per kilogram per dose that you should know? 10. And then how about your frequency? Q6. Okay? And then know that one is a little bit more and one is a little bit less. Okay? So again, if we had little Charlotte, she's our super cute 23-month-old child. She has an ear infection and is advised to use acetaminophen for pain and fever for a few days along with some antibiotics. So could we theoretically calculate a dose for Miss Charlotte? Yes. Beautiful. All right. Our duration of action is about 4 to 6 hours. We have side effects that aren't commonly reported, but GI upset, headaches, and rash. Drug-drug and drug-food interactions are going to be some of our agents like warfarin. So warfarin is going to work in our liver and can impact some of that metabolism pathway. And then alcohol also concerning in the liver, and this is just because we have that box warning of hepatotoxicity, usually occurring when we're at doses of over 7 grams, but we'll see in a couple slides that that can vary from person to person as well. When comparing acetaminophen versus our NSAIDs, acetaminophen is going to be preferred in populations that have cardiovascular risk, renal compromise, GI bleeding risk, and then those that are pregnant. So we're going to talk a little bit about acetaminophen's metabolism. So here we see acetaminophen at the top. I'm looking at the picture. It's also there in words. So acetaminophen at the top, 90% of it, no problem. It's metabolized, it's excreted, no concerns there. About 10% of it, though, metabolizes to a toxic metabolite, so NAPK. This is, you take it, you are ingesting essentially 10% of a toxic thing, right? So 10% goes to this toxic metabolite, NAPK, and our body naturally is going to metabolize it further via glutathione conjugation to make a non-toxic metabolite, okay? Glutathione is naturally going to deplete as we age, as we get other environmental toxins. That can include things like alcohol use, stress can deplete that process, malnutrition, and then any sort of super therapeutic dosing is going to exhaust that process and deplete that available glutathione. So in overdose, there's two things that we need to think about. So one is activated charcoal and N-acetylcysteine or NAC. So activated charcoal is only going to help with that GI decontamination if that ingestion was recent, okay, and that it was oral. Okay. N-acetylcysteine or NAC can be used in any of these different scenarios. So using the Rumack-Matthew nonogram, which we'll show on the next slide here, any ingestion greater than 7.5 grams. If we don't know when they had an ingestion, but we can test their serum level. If they had it and if they took acetaminophen and they have evidence of hepatic injury, and then if they have any delayed presentation. So, oh yeah, I took 40 tablets yesterday, and I'm just admitting it now. So the Rumack-Matthew nonogram is going to be useful for a single ingestion. Can't talk this early. And what we do is we wait 4 hours, and we obtain a lab value of how much acetaminophen is in their blood. The reason why we wait 4 hours is because we're anticipating that there's still drug that's getting absorbed. That doesn't mean that we could get a lab early, just knowing that it's not going to necessarily be plotted on this graph, but we can see where it might fall. So after 4 hours, this graph is developed. Anything above the line, so high levels of acetaminophen in the blood, is indicative of probable hepatic injury, okay? The treatment line is just under that, okay? So if they're inching towards hepatic injury, we're going to go ahead and treat them with NAC. NAC works by replenishing this glutathione supply. Therefore, we're able to metabolize that NAPK, that toxic metabolite. And we can either give it by oral or IV. Has anyone seen this administered orally? Juniors, anyone? No? So the oral solution or mucomist is just diluted. It smells like rotten eggs, okay? If you had an accidental or purposeful overdose with acetaminophen and you present to the ER, I please encourage you not to punish them more by giving them rotten eggs to drink. If they throw it up within an hour, they have to re-ingest it. They have to do that 18 times. Please, please, please do not make your patients do that. Okay? So again, we're just trying to give them a use of glutathione. They're able to metabolize it. We need to replenish it again. So that's why the repeated dosing is useful. The IV formulation is just a continuous infusion. It's kind of stepwise over a day. Okay? So if Kyle, our 29-year-old male, presents to the ED 6 hours after an ingestion of 30 acetaminophen 500 milligram caplets, so we could calculate what this is. Okay, so this is about 15 grams. He complains of an extensive GI upset and depressed mood, poor motivation related to numerous life stressors. So do we have to get a Tylenol level on him? You guys want one, but do we have to? He ingested 15 grams.
7,500 single injection.
Yeah, so we're over that 7.5 grams. So we're going to start it. Okay? We could, and we probably will still get a level just to see how bad it is. Okay? All right. Clinical pearls with acetaminophen or Tylenol. It's going to provide that analgesic and antipyretic effect through that central mechanism. We have risk of hepatotoxicity, and so we need to make sure that we're not exceeding certain doses and appropriately monitoring. It is well tolerated and preferred in select patient populations when compared to NSAID therapies. And then NAC will help replenish that glutathione stores and deplete that toxic metabolite. Questions on acetaminophen? Juniors, we're feeling good. So excited. Riveting morning lecture. See a few smirks. Okay. All right, we're going to move on to antidepressants. These you guys have already been introduced to. So this is just going to be how we use it in a pain condition here. So our antidepressant classes that we commonly use in pain are going to be our SNRIs and our TCAs. How these are working is in that modulation pathway, so that last step. Okay, so pain came up, it went to the brain. Now the brain needs to tell the body to chill out. Okay, so it's going to go back into the spinal cord, and it's going to inhibit that signal from the periphery going into that central. Okay? All right. We primarily are going to use our antidepressants in chronic pain. They're used daily, and chronically, that onset is about 4 to 6 weeks of continuous use. So this isn't for someone that just rolled their ankle. This is going to be someone that has had chronic low back pain or osteoarthritis. We can use these agents as well. Fibromyalgia, which we'll talk about here in these slides. This is important to remind your patients, right? If they're used to just taking an NSAID and they get that relief within 30 minutes to an hour, this is going to be very different, okay? So starting with our SNRIs, again, we're inhibiting that reuptake, so then we have more inhibitory neurotransmitters that are in that synapse to suppress that pain signal. We're working on both serotonin and norepinephrine, so our side effects are going to mirror those things. So I've kind of identified which ones are serotonergic, which ones are norepinephrine based. These are going to be used for both kind of our musculoskeletal, somatic, visceral type pains, as well as our neuropathic pains. Chronically, we use it for fibromyalgia as well. It's kind of a unique one. The 3 SNRIs that are most commonly used are going to be milnacipran, venlafaxine, and duloxetine. They're in order of the most norepinephrine to the least. Milnacipran, you guys probably didn't learn about in your mental health block because it is only indicated for fibromyalgia. It has no mood indications, just fibromyalgia. Venlafaxine has actually no pain indications for it. However, we do use it. It is somewhat cheaper than duloxetine. And then duloxetine has the less amount of norepinephrine effects. It is also a 2D6 inhibitor, which can interfere with some of our other meds, specifically our opioids. And then we have labeled indications for many types of pain conditions. Duloxetine is commonly found in many of the pain-related guidelines as well. Hypertension is going to be associated with that norepinephrine. So certainly milnacipran will have the highest risk of those hypertensive effects to the least with duloxetine. Our TCAs are going to be serotonin and norepinephrine as well, but now we also get anticholinergic, histaminergic, and then alpha antagonism. Primarily, our TCAs are going to be used in neuropathic type pain conditions. These can also be helpful in fibromyalgia. And our side effects related back to those mechanisms, we're going to have a lot. Okay? Anticholinergic, thinking of that dryness. Histaminergic, thinking of that sedation. We have unique precautions with our TCAs, so hypotension, concerns in our elderly and those with seizure disorders, renal and hepatic impairment, and then QTC risks. It is contraindicated, our TCAs, in those that have had recent MIs. An overdose is fatal due to cardiac dysrhythmias. So making sure that we're trying to limit and avoid these in folks that have a history of suicidality or risk-taking behaviors, and even those that have memory impairment. Yeah.
So we keep learning about TCAs, we keep learning how basically inferior they are to all the other meds. Why don't we even still touch them? I mean, what would be the case that I would give a TCA over SNRI or SSRI or whatever it has?
Perfect. So question here in the sophomore class is regarding, TCAs are kind of a garbage drug, right? I'm paraphrasing. That's not what we said. So why do we keep using it, right? Why does it keep coming up and keep being integrated? And so sadly, we have mainly, 80-ish drugs that we could use for pain. And of that, 10 drug classes? So the concern is when you've tried everything, what else is there? So TCAs can be helpful. Usually when we're leaning towards a TCA, it's someone who also has concurrent insomnias or sleep disorders, because it's going to be very sedating, where SNRIs are going to be more activating. Usually that's where we lean for it. I'll also use TCAs thinking about the different mechanisms, that I would rather put them on a TCA than 2 of other drugs and see if they can tolerate the side effect profile. But certainly in my elderly patients, I'm not picking TCAs. Other questions? I see some approval to that. All right. So the 3 TCAs that we commonly see, so amitriptyline is going to be what we call a tertiary amine, meaning it has more side effects, mainly sedation. And it actually metabolizes to that bottom one, nortriptyline. Amitriptyline has more of that serotonergic effects, where nortriptyline has more of the norepinephrine-based effects. Doxepin there in the middle is a compounded medication that we can do for theoretical topical use. However, it is purely transdermal. So it's a super expensive medication that you compound, you put it on, and it just goes straight into the circulation. Okay, so that's how it's marketed, but you really don't see that it's helpful. A reminder with our antidepressants, though certainly many of our medications moving forward will also have serotonergic effects, but we need to remember serotonin syndrome. This is going to occur whenever we have elevated levels of serotonin. It's going to be a sudden onset, usually within 24 hours, whenever we have an introduction of a new agent or there's an increase in that concentration. So someone might get sick, they might not be eating as much, they might not be metabolizing as much. Now we have an increase in that serotonin. How I counsel my patients is I think of mind, body, and muscle, and I literally do this movement. Juniors, I hope you can see me, but I pretend I'm a flight attendant, effectively, of mind, right? You're going to be confused, things aren't going to make sense. Your body, you're going to be sweating, you're going to be tachycardic. I don't use that word with my patients, but your body's not going to feel good, and your muscles are going to be twitching and jerking and all these different things. Show of hands, who's seen serotonin syndrome? 3 here, anyone in juniors? What did you guys notice when you saw it? Did it look comfortable? Super anxious? Flushed, okay. I've seen it about 3 times, and every time it just looks like these people want to get out of their skin. It's the weirdest thing to explain. You can talk to them, you like, hey, let's sit on the bed. They can't even do that. They are jumping up, they are moving around. They look so uncomfortable. I've also had patients in pain clinic who have mild serotonin syndrome, which I don't think is a thing, but my docs assure me that it's fine, that are okay having a little bit of a tremor, a little bit of a tachycardic episode, because their pain is controlled. Okay, so I work with them about identifying the different signs. If they were to have concerning serotonin syndrome, we're going to stop any agent first that could cause serotonin. We could give benzos to help with the tremors, and then we could try reversing that serotonin effects with cyproheptadine. So back to Scott. Could we give him an antidepressant? Maybe. Okay, SNRI or a TCA? So does he have neuropathic pain or nociceptive pain? Chronic axial low back pain with degenerative changes. We're going to do a show of hands, both classes. Who says that this type of pain condition is neuropathic? Who says it's nociceptive? Not a lot of hands. Okay, so musculoskeletal, nociceptive type pain. Which of our agents are going to be more appropriate, our TCAs or an SNRIs, or a nociceptive type musculoskeletal pains? Who says TCAs? Show of hands. Who says SNRIs? Beautiful. Okay, so we could give Scott an SNRI. Okay. Which SNRI could we give him? Duloxetine. What else? Can we give him milnacipran? We could. It'd be off-label. So milnacipran is only for fibro. And we could also give off-label venlafaxine or Effexor. Okay? Yeah, so also realizing, right, his mindset is this tough it out approach. Probably would have to do some counseling, some good motivational interviewing with him to help see if there's buy-in there. Usually how I present that is most of the guidelines don't have a lot of robust evidence or recommendation for certain medications. So for example, the chronic low back pain guidelines, the 2022 of the VA, their recommendation is no meds. They have no meds that are fully recommended, that they strongly support. The only two medications that they suggest trying, one is an SNRI, specifically duloxetine, and one are NSAIDs. That's it. So usually when I get folks in my clinic, I'm getting patients like this that I am needing to educate and motivate that, you know what, the guidelines kind of only offer this other thing. It's not this gabapentin, it's not this opioid, it's not all those other things. Those are actually recommended or suggested against. Okay? But again, that is outside of the scope of this lecture. So clinical pearls with our antidepressants, SNRIs and TCAs can be used in chronic pain states due to that modulation that's happening in that CNS. We have unique side effects among the agents that will guide the appropriate selection, and then making sure that we're aware of that risk of serotonin syndrome that could be fatal. Questions on antidepressants? All right, anticonvulsants. I believe you guys have been introduced to these. Some yes, some no. I believe it might be upcoming for the sophomores. Seizure disorders? Yes? Yes? Cool. Okay. All right. So there's numerous oral agents that could be used for pain. Again, these are another class where we need daily chronic use of these therapies to have that effective change. The four main types are going to be our gabapentinoids, our traditional anticonvulsants, so some of our older school agents. Our benzos, we have numerous types of benzos, and then topiramate is kind of on its own island. Mechanistically, all of our anticonvulsants are going to slow the action potential. Okay, so now we're reducing that pain signaling, and it's going to vary which agent you're using, whether it's a calcium chloride or sodium change. We can see the specific mechanism of them here. We'll talk about each of them on each slide coming forward. And these are primarily going to be used in neuropathic pain conditions. Again, fibromyalgia and headaches can also be situations in which anticonvulsants might be helpful. So starting with our gabapentinoids, we have gabapentin and pregabalin. Pregabalin is a controlled substance 5. These are going to work on the alpha-2 delta subunit, which is a calcium channel. Primarily using these again for neuropathic pain conditions, but we can use gabapentinoids for a whole host of different things. Leave it at that. Dosing, as we'll see if all of these, is that we need to start low and titrate slowly. doing this no sooner than every 3 to 7 days usually for this titration. And we do need to renal dose adjust our gabapentinoids. Side effects, we'll often see drowsiness and dizziness, headache, ataxia, fatigue, and nausea, and then edema can result in weight gain. So if folks mention that they've gained weight since being on it, likely it's an edema response. In 2019, the FDA did alert that there is fatal respiratory depression that's possible with our gabapentinoids. This came after guidelines really shifted away from opioids and instead to use concurrent gabapentinoids with opioids. From that, we then found that more people were dying. Okay, not great. So they came out with this alert in 2019 saying that those that are on concurrent respiratory depressants, so things like opioids, those that have any sort of respiratory condition at baseline, and the elderly could all be at risk. Our traditional anticonvulsants, so carbamazepine, oxcarb, and lamotrigine, are going to be blocking our sodium channels. Also useful in more neuropathic pain conditions. Again, we're starting low, we're going slow. We might consider drug level monitoring. Side effects, again, we see that dizziness and drowsiness, headache, and GI upset. And then a unique one specifically with lamotrigine are skin reactions. And then metabolism, we have a ton of drug interactions. And so being mindful of that whenever we're choosing these agents. Usually I defer these folks to neurology if we're thinking about using these products. Our benzos are going to be C4s. These are going to work on enhancing GABA A, which is an inhibitory process with that chloride influx. These are usually classified in our anticonvulsants. However, their use is usually for muscle spasticity, which we'll talk about in the next section. We have box warnings as it's a controlled for things like withdrawal symptoms such as seizures, and then certainly that risk of abuse, misuse, and addiction. And then topiramate has multiple mechanisms. So we're working on sodium, calcium, and GABA A. We can use it for, again, that neuropathic pain conditions, fibromyalgia and migraines. Side effects here is that we have brain fog. This is fairly common. Usually it gets its nickname of Topamax is its brand name. We jokingly call it Dopamax because it makes you feel dopey. Weight loss can be sometimes a beneficial approach. So in chronic pain conditions, folks are more apt to gain weight just because they're not as active. And so this might be a helpful push to get some of these folks to be more engaged and active if they're able to lose a little bit of weight. Contraindications, there's a high risk for metabolic acidosis and then a risk of kidney stone development as well. Making sure that these patients are maintaining hydration, and we do actually dose reduce as high as 40 mils per minute for this one. So thinking about our anticonvulsants, if we have Paul, he's our 68-year-old male. He's concerned for unmanaged restless leg syndrome that's preventing him from getting comfortable at night. He has a past medical history of hypertension, hyperlipidemia, prediabetes, nephrolithiasis, acid reflux, eczema, and atopic dermatitis. He's the primary caregiver for an aging parent, and he's on 20 plus agents and supplements. So let's say we want to put him on topiramate. Why might he not be a great option for topiramate? He has kidney stones, brain fog, right? We don't want him to have brain fog, okay? What about some of the other medications, the traditional medications? Any concerns with those? Drug interactions, skin issues, good. How about then benzos? Probably don't want that sedation risk, right? We want him to really be present. Gabapentinoids? potential weight gain. Drowsiness, dizziness, okay? If we had to pick one of the options. So gabapentinoids, and when we look at our indications, they do have restless legs listed specifically, okay? So of all of them, I've given you kind of some contraindications as to why we wouldn't choose some options, and I've tried to lead you to why we might choose gabapentin, okay? Your exam cases will not be this complex, but these are real type patients, right? That you have to be thinking of, okay, you have this restless legs. I think then of this drug class. Of those 10 options, which of those is the best? Okay. So again, clinical pearls with these, we think that these are going to help suppress that action potential due to these different either calcium chloride or sodium channels. They're primarily going to help in neuropathic pain conditions. We're going to start low and go slow, and then most of the time they have that CNS depressive effects. And then again, which agents are in each class are listed there. We're going to go ahead and break early to come back early. So let's be back by 8:57.
We have a question that it sounds like a couple of people have asked.
Just one person.
No.
That's me.
Somebody else asked a similar question.
Okay. Hi, good morning. Oh, that's loud. Good morning, ma'am. Could you clarify with regards to the NAC? Are we, because you mentioned that there was a delay in presentation, do we have to delay the administration of NAC if it's under a certain dose, or can we go straight and administer after after that 7,500? Just a little bit more on the administration of NAC. Thank you.
Perfect, thank you. So with, let me just go back to that slide here. So talking specifically about utilizing the Rumac-Maffei nonogram, so this is kind of two parts here. So Rumac-Maffei nonogram is only going to be useful in patients that have an ingestion and it's been beyond 4 hours. And that is just because here, let me turn my phone around. So here is the first 4 hours after an ingestion. So the concern is that there is nothing available on this nonogram, on this graph, that gives you any sort of guidance, right? And so that's all that this graph is saying, that you essentially need to wait 4 hours until the graph is useful. However, if after 2 hours you have a point that's up here, likely you can assume that they're going to keep increasing as we continue into this area right here, right? So likely you're going to still get a level and you're going to go from there. So that is strictly when you're using this graph. However, based on this one, right, when we have all these different uses for NAC, if someone comes in like Kyle did and he had a 15-gram ingestion, that's going to meet the second bullet here. We're going to go ahead and start NAC ASAP. Okay? Not APAP. Good one. Tylenol's drug name one. Little old drug humor for you. Questions or clarification needed further on that one? Feeling good? Okay. All right, other questions? All right, so now we're going to pivot to skeletal muscle relaxants, spasms and spasticity. First, we need to know the difference between spasms and spasticity. So spasms are going to be involuntary muscle contractions. They're going to be presented with jerks, twitches, cramping, usually caused by musculoskeletal pain, myofascial pains, mechanical low back pain, herniated discs, and spinal stenosis, and the treatment duration for spasms is going to be an acute short duration. In spasticity, this is a velocity-dependent increase in that muscle tone. This is that stiffness, hypertonicity, hyperreflexia, Usually we see this as either an MS presentation or a CP. Spinal cord injuries and traumatic brain injuries, as well as post-stroke syndromes, can all have this spasticity presentation. And this is a chronic complication, and so we treat it chronically. The medications that we see are going to be divided into the ones on top are our spasms medications. We can remember these with the mnemonic of "oh my cramps." Okay, spasms, we're cramping. Oh my cramps. All of the drugs for spasms either start with an O, an M, or a C. All the ones for spasticity on the bottom here, we can remember by deep body tension. And again, all the drugs that are here start with a D, B, or T. We'll start by going through our agents for spasms, and then we'll transition to those going through spasticity. And then again, as with our other classes, we'll bring it all together with some cases. So cyclobenzaprine or Flexeril so all of our agents for spasms, they work by depressing the CNS. We don't always know why they work for spasms. Okay? So cyclobenzaprine or Flexeril, mechanistically, we're going to classify it as a CNS depressive. It is structurally similar to TCAs. So here we can see the chemical structures of amitriptyline and nortriptyline and cyclobenzaprine right in the middle, and all that's different is a double bond, so one less hydrogen in one area, and then that's it. Okay? So people should not be on both a TCA and cyclobenzaprine because it's effectively the same drug. Side effects are going to be similar to our TCAs. So thinking of that dryness, that sedation, that serotonin syndrome. Also going to be contraindicated in those that have those arrhythmias and cardiac conduction abnormalities. And as we saw with TCAs, we can have seizure threshold changes as well. Being cautious with those that are using alcohol and concurrent CNS depressants, and then the elderly population. The next two have, metaxalone has a wonderful brand name of Scalaxin. We don't really know how it works other than it's a CNS depressive. It has dizziness, confusion, and again, it has some lovely serotonin syndrome, so it likely works somehow with serotonin. Chloroxazone or Lorazone has, again, CNS depressive effects. However, it has fatal hepatotoxicity, so we don't use it. Okay? We do need to monitor hepatic function. We don't want our patients to die. All right, methocarbamol or Robaxin, very commonly used, especially here in the military. CNS depressive, we don't know how it works. We can give it either oral, IM, or IV. Dosing, unfortunately, it has an extremely short half-life, so we have to give repeated dosing for it multiple times a day. Another thing that's unique about methocarbamol is it has what's called rapid tachyphylaxis, which just means that it kind of depletes how it works very quickly. So after 72 hours, we don't believe that it's truly effective on treating those spasms. It might still have that CNS depressant effect, but it's not actually helping with those spasms anymore. Side effects with this one, a unique one is that we have this urine discoloration, but again, we see this sedation and dizziness as we've seen with other ones here. And then methocarbamol also lowers that seizure threshold, so being careful again in those that have other sedation and dizziness type pictures. Orphenadrine or Norflex, again a great brand named drug to remind us that it's for spasms. This is actually an analog, meaning that it's structurally similar to that of Benadryl. So this one, we just throw on this little methyl group, so another carbon. So we're going to have very similar effects that we see if someone were to take Benadryl. We're going to have a very extensive hepatic metabolism where we can get euphoric with it, and then making sure that we're cautious in the elderly, and then contraindicated in all of the populations that we would think of with some of that anticholinergic activity as well. All right, the last one for our spasms is going to be Soma. This is a C4. Its mechanism, we do slightly know, so it's going to be a CNS depressive, but it also has a GABA A agonist effect, and that is because its metabolite is actually barbiturate-like. Okay, so barbiturates are similar to benzos, and so barbiturates are going to have that effects at that GABA A receptor. We need to use these again for that short-term use, as with all of our agents for spasms. Side effects, we can think of it similar to if we were to take a barbiturate, so concerns with dependence, withdrawal, and seizures, and then making sure that we're avoiding it in our elderly and certainly pregnancy. So then that transitions us over to spasticity, and this one is slightly linked to our last one, is going to be our benzos. So our benzos also are going to be GABA A agonists. We can give many different routes of these. There are specifically with diazepam or Valium, which we'll use mostly specifically in spasticity. It can be helpful because it has an extremely long half-life. So in a chronic spasticity-based condition, we want something that works really long. So diazepam can be helpful there. It has many active metabolites, and those metabolites even have longer half-lives, so this one stays in the body for a while. Side effects, that dependence and withdrawal, and then those boxed warnings with our concurrent opioids, certainly that abuse, misuse, and addiction, and then potential fatal withdrawal. All right, while it's not a GABA A agonist, we have a GABA B agonist with baclofen. This has inhibitory effects, so again, we're just changing that synaptic reflex in the CNS and causing that hyperpolarization. This is one of those agents that could be given orally, but we can also give it intrathecally, so into those pain pumps. Side effects, dizziness, weakness, and drowsiness. However, you will adapt to that with prolonged use, and we can get some hepatotoxicity as well. There is a unique box warning with this one in that we can get withdrawal that could cause death. Specifically, that's speaking to those that have the intrathecal pump, okay? So this is one that if you're in the ED or your patient calls you and is like, yeah, I have this like hockey puck in my stomach and it's beeping at me and I don't know, I think it's dead and it's not infusing anymore. Your first question should be, is it baclofen? Okay, if it is, you could die. So we need to treat you ASAP. All right, moving on with other spasticity agents. We have dantrolene. This is a direct peripheral action, so we are working on the muscles themselves with this one. We could give it either oral or IV. Orally is going to be for spasticity. IV we're going to be using in the OR for malignant hyperthermia, which is just a rare life-threatening muscle fiber breakdown, and that's just because certain anesthetic agents can result in that. Side effects, again, we see the CNS depression, hepatotoxicity, and that hepatotoxicity can be fatal. All right, a few more. We have tizanidine or Xanaflex, another good one to remember that it is for our muscles. This one actually is an alpha-2 agonist. So other agents that are alpha-2 agonists are things like clonidine. Okay, so we might have a side effect of rebound effects, specifically with a hypertensive, hypotensive type picture because of that mechanism. And we do need to both renal and hepatic dose adjust. This one we also see hepatotoxicity. And then our last agent here is going to be botulism or Botox. This is again a direct peripheral action with these. These are going to be used in conditions such as chronic migraine or limb spasticity. This is going to be an IM injection at that peripheral site. Dosing is usually every 3 months. There is a box warning for risk of migration. So if you inject it in one area, we don't want it to migrate and paralyze other muscle groups. So I mentioned kind of repeatedly through these different agents that there's hepatotoxicity concerns. So those that have little evidence of hepatotoxicity concerns are listed there. Tizanidine and baclofen have rare but significant cases of hepatotoxicity, And then the two agents that have fatal hepatotoxicity are going to be that chlordoxazone and dantrolene. Tizanidine specifically in the package insert states that after 1 month of use, you have to re-monitor their liver functions because of this potential risk, and that can be up to 5% of patients. So usually we consider that for most all of our muscle relaxants that we're giving when folks are taking them on a more chronic basis. Okay. My mnemonic that I remember with I can't say it right now, I don't know why, but the mnemonic is clear zone of death. So C zone is going to be your first drug, of death is going to be dantrolene. So if we have Alice, she has intermittent acute muscle spasms during her fibromyalgia flares. They occur every 2 to 3 months and they last for 1 to 2 days. So which grouping of medications are we going to think about first for Alice? Spasms, oh my cramps, or spasticity, deep body tension? Come on, guys. Yeah, short term, right? It happens very short term. It's spasms. It says it in the stem there. Okay, so we're going to choose our spasms agents. Alice is going to be saying, oh, my cramps, right? That's going to remind you which agents. So if your multiple choice options give you something that's in not those letters, probably don't pick those, okay? She's also taking alprazolam, Buspar, duloxetine, and pregabalin. So this would be fairly typical to see someone who has fibromyalgia also being prescribed these medications. So then of our agents that we can use for spasms, what are our thoughts here? Are we concerned about any drug-drug interactions? So serotonin syndrome, okay? So there's some that cause that. Anything else? Potential seizure disorders, right? So what is she using the alprazolam for? What is she using the pregabalin for? Thinking that she's on a benzo currently. Are there any agents that have metabolites that are benzo-like or barbiturate-like that we might not want to use? Do we care about Alice's liver? We care about everyone's liver. Yeah, we like Alice. We want her liver to be working. So maybe we don't give her something that's fatally toxic to her liver. Okay? So again, thinking through some of these cases, thinking about what could be going on. Certainly it's going to be hopefully much more straightforward to you guys when you guys are taking the exam and getting your patient cases. So what about Sarah? She has ongoing muscle spasticity throughout her neck, scalp, and shoulders that are worsening her migraine.
So what are we giving her?
So the question is, what are we giving her? And I would defer to you guys, right? So you identified potential serotonin syndrome risks, right? You identified the benzo, barbiturate potential concerns, right? So I'm just trying to get you guys thinking about why some agents might not be ideal, not necessarily what is the answer, okay? So just to help remember, right, what are the objectives of this lecture, which is to know what are the indications, which we talked about, right, spasms, what are some of the side effects or concerns, okay? So let's talk about Sarah. She's our 56-year-old patient. She has ongoing muscle spasticity throughout her scalp, neck, and shoulders that worsen her migraines. And she struggles to remember to take medications, and she dislikes feeling groggy. Okay, so can we give her benzos? Right, like we could give her anything. Do we want to give her benzos? Probably not. Why? Groggy, good. She might not remember to take it. How about dantrolene? Oral dantrolene works great, right? It could kill her, right? We like Sarah's liver just as much as we liked Alice's liver. So we're probably not going to give her dantrolene. Could we give her baclofen? We could. Okay. What limitation does baclofen maybe have? Some potential CNS stuff. Okay. So she doesn't like to take an oral med. She struggles to remember that. So you could tell her, you know what, Sarah, let's set an alarm on your phone together. I'm really good at technology. Let's do this, right? She's having local muscle tension. We could give her Botox. What? Okay. So again, thinking about some of the indications, thinking about some of those side effects again, and making it patient specific. Tizanidine is the other one that we didn't talk about. Again, that's just a daily med. Might make her feel groggy there. All right, last one here, we have Russ. He is our lovely 79-year-old male. He had an ischemic stroke, and now he has ongoing spasticity from that, so he has a post-stroke syndrome. And it limits his mobility and ADLs. We can see his vitals here and his medications. So which grouping are we thinking about for Russ? Spasms or spasticity? Spasticity, okay? Then we can think of our deep body tension. We can think about what meds those involve. And then we can try to figure out, right, pros and cons to each of those that we might want to give Russ or might want to avoid in Russ. Okay? So, right, Sarah, we could give Botox. Are we going to give Russ Botox? Probably not, because it's not localized. Okay? And then you guys can kind of work through, all the rest are kind of like maybes, but there's bad things with each of them. So thinking about kind of those pros and cons there. Okay? So to summarize, these are all of our agents. This is a good summary page. It is not all-inclusive, so please use everything else. But here we kind of see the quick notes on each of those agents. So overall, our clinical pearls, there is no one-size-fits-all muscle relaxant. We're going to classify them based on their indication and their mechanism. Thorough assessment of risk factors and side effects need to be considered, and then considering that dose adjustment or rotation to another agent if we need to. Questions? Juniors, questions? Looking lively. All right. Few slides here about some of our other analgesics that don't fit nicely in any of our other categories. So NMDA antagonists. So we talked a little bit about NMDA processing when we talked about which herbal. It was an NMDA plug. Magnesium, yeah. So magnesium is an NMDA plug, and that NMDA is this revving cycle, right? So I think of it like this race car, right? We're just revving it up, and that pain is just getting worse and worse and worse. And so NMDA, we can try to reset this pathway. We can block these receptors, antagonize them in this central sensitization pathway. So some agents that we might use, ketamine, certainly is the one that we commonly think of from a pain standpoint, but oftentimes we use it in anesthesia and as a sedative agent. But things like memantine, which we use in Alzheimer's disease, and things like amantadine, which we use in Parkinson's and then for influenza A. So they're all working in this NMDA antagonist pathway. And again, this is causing that inhibition of glutamate binding. Therefore, we don't have that influx, and so we don't have that action potential. Another agent that came on the market a year ago now is suzetrigine or Jornavax. If anyone has gotten surgery within the last year, I would say, or their loved one has, I would not be surprised if they got this medication. So this is something that was fast-tracked by the FDA. So sadly, there is this, sadly, unsadly, I don't know. As a pharmacist who works in pain management, I think there's a lot of policing on opioids. And so we're turning to other agents and we're verifying them very quickly without the same rigor of studies that we normally would. And so Jornavax came to the market last year, and so we don't know a lot about it yet still. How it works is it's working in the periphery, and we are inhibiting these peripheral nerves that are working on this pain signaling. So it's helpful in the sense that we're taking the pain, we're blocking it in the periphery, it's not going to be getting to that spinal cord and going up to the brain. So similar to lidocaine in the sense that it's a periphery thing, okay? Yep, and it's also a doing that process, right? How it's been approved is for moderate to severe acute pain, specifically procedural pain, and it's for a 2-week course. So you get your knee replaced and then you take this for 2 weeks. There's a loading dose and then a taper associated with it. It's at least a twice-a-day medication, and it is both a 3A4 substrate and inducer, meaning that we're going to have drug interactions, and one of its metabolites is an active drug as well. How we can remember this one, so Jornavax, NAVX, is it's going to work on the Na sodium voltage channel, and it's blocking it. Oh, love it, right? AI didn't come up with these things. This is all big brain up here. All right. And then our last other one that we'll talk about is going to be ziconotide or Prialt. This actually comes from the cone snail venom. And so it's this really big, nasty structure, and it's really awesome because we place it intrathecally. That's the only route that we can use it. We use it for severe chronic pain, and it is going to be binding to those calcium channels, preventing that pain signaling. The side effect is unique in that it really only has this confusion and cognitive impairment that is reversible with dose reduction. Okay. So clinical pros on these agents, they're non-opioids, they have unique targeted mechanisms, and these agents have tolerability and dosing nuances that may make them concerning options themselves. Other questions? We went through a lot so far. How are we feeling? Feeling like we'll revisit it later, it sounds like. I'm going to take a quick pause here just to pivot briefly, and then we'll start into our opioids. So on the materials that you guys have in Canvas, Hart, if you can confirm that the juniors can access them, that would be wonderful. But you guys should have, there is a one-page front-back summary sheet of all of the different medications and classes with a very broad overview of what we need to remember. I very much wrote it for when you guys are taking your big test of, hey, I only have 10 minutes to, remember what we talked about in pain, right? So help to really refresh some of those things. Certainly we'll look at a few more nuances for the exam, for this exam. And then the next 3 pages are mock questions, okay? So it's, again, to help think and dissect of, okay, so the first question is, hey doc, I had this pain patch when I was up in Alaska. Can I have that again? And so it's a way to help think of what were all the products that were patches. You guys have a table that is mostly filled out. Some of the meds are missing, some of the mechanisms are missing, some of the side effects are missing. And so it's another way to try to put some of those pieces into that, similar to what the exam might have, right? I might ask you, what is the indication for a lidocaine patch? And you would have to tell me, right? So it's just other ways to help organize it And again, there's, I think, 9 different types of questions like that to help categorize those things. The memory joggers, which we'll again revisit tomorrow when we start class. And then as we get into opioids, there's a couple opioid support things as well. You guys will be expected to do an opioid related calculation. And so that calculation, there's a supplemental worksheet. If you need more help to make sense of how to utilize the table, you can use that worksheet. I think there's 14 questions. If you understand it right away and it makes sense, I don't think that you need to do the worksheet. If you feel that it would be helpful to get that practice and to get faster at it, I think that could be helpful as well. Okay. Thoughts, questions before we start with opioids? All right. So opioid therapy, I've tried to break it down into the overview, some tolerability concerns, some safety concerns, the specific agents themselves, and then how we dose opioids as well. So taking a step back of just kind of what are opioids, what is the mechanism, how do we use them, how helpful are they actually, and what are different dosing approaches that we can use with them. So this is a somewhat busy slide, but they are going to help with modulation. Okay, opioids are helping with that modulation in that descending pain pathway, that 5th step. We're inhibiting that transmission of that ascending pain, and therefore we are altering that perception as well. We naturally have endogenous opioids in our body. That's how we are able to cope with stuff. If I touch a stove, my body is then going to naturally produce more opioids and send them to that modulation track, right? Before I get to the hospital, and then you thankfully give me some morphine or something, right? We have both presynaptic and postsynaptic mechanisms here, so we have calcium and potassium involved in these pathways. The majority of our opioids act by agonistics, so we are binding to opioid receptors and we are encouraging that receptor to work, okay? When we do that, we're going to get this pain reduction, but we can also get things like sedation, respiratory depression, euphoria, and dependence. We have additional opioid receptors, however, so we specifically have the mu receptor, which is our most prevalent receptor and most commonly targeted among our opioids. Our mu receptor is also primarily going to be responsible for causing meiosis or constriction of the pupils. It's also largely going to be responsible for the GI-related constipation that we have. Note that constipation does not improve with ongoing use. Okay? And then histaminergic affects that mu as well, so we can get things like pruritus and then vasodilation. Delta receptors, we have very limited data on them. And then kappa receptors can actually cause dysphoria when we activate those. So when we think about how opioids work, we can think of our agonists, and I picture this like saloon doors. Okay, so you go through a saloon, you open up both of the doors. That's what we're doing with a full agonist. We're stepping through, everything's happening. With a partial agonist, only one of those doors open. So the effects still happen, but maybe not all of them or not to the same extent. Okay, so it's a little bit blunted. When we think about antagonists, the doors just stay there. No one comes in, no one comes out, but we're not changing anything. And then an inverse agonist is opening the doors the other way. Everything's coming out. We're doing the opposite effects that we should be doing. Business is bad, okay? So agents that are agonists, these are going to activate the receptor, and we have no ceiling effects. Everything that could be happening there is happening there. Things that we think about are many of our traditional opioids, so morphine at that mu receptor, oxycodone, fentanyl, and methadone all have full agonist effects at the mu receptor. partial agonist effects, so this is partially activating the receptor. This means that we have some ceiling effects or some sort of modulation or moderation that is happening there. So buprenorphine is commonly a partial agonist at that mu receptor. Antagonists, we just sit on that receptor and we don't do anything. Okay? These are going to be naloxone and naltrexone are some examples here. So we're just occupying. That means that we're blocking both positive and negative activity there. And then inverse agonists, so the opposite action, we see with buprenorphine actually has kappa, has an inverse agonist effect. And if we remember from the last slide, kappa causes this dysphoria, and so buprenorphine actually helps with more of a clarity picture. Okay, so we see that it has a partial activity at mu, and then this opposite activity making it a little bit more clear. So it's a little bit of we consider it a safer medication due to some of those mechanisms. Questions on opioid mechanisms? How do we use opioids? So there's many different formulations. We also classify them based on immediate release or extended release. Long-acting formulations, so extended release formulations, should only be considered in patients who have already become tolerant. Their body is used to short-acting medications. Our indications for use, we can use them for some non-pain things, so dyspnea and cough, as well as diarrhea and then opioid dependence. This partially goes to the fact that we're suppressing that respiratory drive with that dyspnea and cough. And then from a pain standpoint, as we already mentioned in the intro, ideally we're going to limit our opioids to those severe acute pain episodes, such as that procedural or in an acute injury. In moderate to severe cancer-related pain, because that's based on which approach? The WHO ladder. Yep, that WHO analgesic ladder. In settings of palliative care or end of life, and then in severe refractory pain, and again, that's somewhat controversial. And why is it controversial? Well, chronic long-term opioid therapy has not demonstrated functional benefit. Okay, and that's really what we care about in pain management, is that we want you to be functional. Okay, just because you feel better, but you're not able to walk your dog any further, or you're not able to get out or be more engaged in the community, right? Those are things that we really want to be focused on. So the FDA has actually proposed last year, and they're still in the works of it, of trying to figure out what is the data. Is there anything that we could do or other approaches regarding this appropriateness? We can use screening tools to evaluate how effective opioid therapy is. So there's the PEG tool, which is just a subjective screening, and it asks the patients what their pain levels are on 3 different areas, and then we can use that to determine if opioid therapy is effective. How we dose opioids, there's 2 main approaches here. So we think about either around-the-clock dosing or a basal dosing. This again is going to be more either of a chronic approach or something where we have a very high pain need. I think of this like an ocean, right? If your pain is already flooded up to here, we need to treat that all the time. The ocean is going to be there regardless. Okay? At times, though, a little tidal wave comes in, right? And that's when we go to our as-needed dosing. So whenever you have a tidal wave, you can take an as-needed. But otherwise, we need to take something that's a basal. Our around-the-clock basal dosing is often going to be expressed in our long-acting therapies, and they should only be considered, as I mentioned, in patients that are not naive, so they are tolerant to opioids. The as-needed dosing, those tidal waves, are going to be using short-acting therapies. So that tidal wave comes and then it goes away on its own, but we want to try to hit it and bring it down quickly, but we don't need that to last a long time. So we can use our short-acting or our IR therapies, our immediate release. Those that are on a basal around-the-clock dosing should also be given a PRN breakthrough dose of those tidal waves. Okay. Another term that we use is called total daily dose, which is just the 24-hour dose that has been administered. So usually we'll, for inpatient, we'll see a patient one day, we'll say, what's your total daily dose? We'll calculate how many doses they received of both their long-acting and their short-acting. We'll put it all together, and then we'll make a new regimen for today based on that number and how well their pain was treated. There's ways that we can do this. So if we use a continuous dosing approach, this is going to be at a constant rate. This is going to be achieved with different sorts of infusions. So we could do sub-Q IV or intrathecal, or patches. So there's a couple opioids that do come in patches. And then when we do have infusions in the hospital, they're going to be placed in a lockbox. Okay, so then family members can't go and take their fentanyl bag or something like that. They're going to be in a lockbox next to them. Patient-controlled analgesia, or a PCA, is this little call button type thing, or a push button that is bedside. It is hooked up to an infusion pump, again, sub-Q IV or intrathecal. So as I was talking about how patients can go onto their phone with intrathecals and do push doses, that's a form of a PCA. So they're just pressing this to get a demand dose. You guys are the ones that determine what that dose is, how often they get that green light that they can press it. All those different nuances are on that order. It's a preset that you pick. You choose what that lockout is. So again, how often do they get that green light to do it? They can also be used in addition to continuous. So someone could have a continuous rate of morphine and get a push dose from that same bag of more morphine. We don't want to give PCAs to patients that are having family or staff press the button. Well, the light was green and they were sleeping and they appeared comfortable, so I just pressed it. Right? That's not the intent of using that. If we're treating non-pain symptoms, so if they're anxious because you just walked in the room, oh my gosh, the doc's here, like, yikes. Or if there's any barriers to physically press it. So if they've had a stroke, if they have Parkinson's, if there's any issue where they physically don't have that dexterity to appropriately press it, we won't use them either. So clinical pearls, when we're thinking about this piece of opioids, these agonists are going to suppress that ascending pain signal through modulation and pain perception. They may exhibit that full, partial, or inverse agonistic effects at those opioid receptors. We want to use them selectively and in appropriate situations, so those 4 cardinal bullets there that we talked about, using them for the lowest effective dose for the shortest amount of time, and then knowing that opioids can come in many different formulations and we can dose them in a variety of different ways. Questions thus far? All right, a little bit more here. So talking about opioid tolerability. So how, what are some of the side effects? How do we manage those? And then precautions, and then opioid use disorder here. So common side effects that we think about with opioids are going to be nausea and vomiting, constipation, particularly with that mu receptor, histamine release, CNS depression, and respiratory depression. Chronic use of opioids can get these long-term side effects. So things like decreased libido, decreased mood. We can actually increase our risk of having fractures, immunosuppression, and then increased cardiovascular event as well. So 2 times more likely to have a heart attack in patients that are on chronic opioids. What we might do to change some of these outcomes is either to reduce the dose, change to a different opioid, use a different route of the opioid that we're using, or just manage the symptoms. So putting those things together in a little table here, nausea and vomiting we do believe is going to resolve with time. We could also try to reduce the dose of the opioid that we're using, or we could consider rotating to a different opioid that maybe doesn't have as much of a nausea component to it. However, we could just give them an antiemetic. Right? Here's some Zofran, hope that helps. Really hope that your pain stays controlled with this regimen. Constipation, we can dose reduce. We don't really think we know it's not going to resolve with time. And we don't think that opioid rotation is going to really help it, but we could try it. Usually we need to add an alternative regimen here. So either a stimulant laxative or a peripheral opioid receptor antagonist, meaning that we only want to block the opioids in the gut, right? We don't want to block the opioids in the brain. Histamine release primarily is going to be improved with changing to a different opioid. So some opioids that we'll talk about are more likely to cause this histamine release. We may just use an antihistamine to help manage these symptoms. CNS depression, we can reduce the dose. We can also give a CNS stimulant, so things like Adderall and other amphetamines to increase that effect. Respiratory depression, we need to have a central opioid antagonist. Okay, we need to go straight to the brain. We need to antagonize those things that are going on. We do not want to have respiratory depression. And then the last concept on this one here is going to be opioid-induced hyperalgesia. So this is a theory that we have increased pain with ongoing opioid use. Okay, so something that's painful just becomes more painful. We can try to dose reduce. We can try to change to another thing, or we can try to give other medications to help manage that new opioid-related pain that has been caused. So the unique one here with constipation, that peripheral opioid receptor antagonist, the one that we're going to think about is methyl naltrexone or Relistor. Again, this mechanism is that it's a peripheral mu receptor antagonist. Naltrexone is an antagonist that we'll see that works centrally. When we add a methyl group onto it, so methyl naltrexone, it becomes really big and bulky, and it's not going to cross the blood-brain barrier. Okay? So that methyl group means that it's solely in the periphery. Okay? Meaning we can use it concurrently with other opioids. Our main use is going to be that opioid-induced constipation. We can give it either orally or sub-Q. So if we have Harold, he's our 63-year-old male. He was newly started on opioid therapy for severe cancer-related pain. So is opioid therapy appropriate in him? Yeah. Who Ladder says, sorry, Harold, but yes, you can have it. He wants to ensure that he'll be able to maintain a high quality of life and minimize any potential concerns associated with the therapy. So what things might we think about for Harold that he might encounter when we start him on opioids? Okay, so how do we need to dose it, right? Is it going to be a chronic dosing? Is it as needed dosing? Let's assume he hasn't started anything yet. Which approach would we start with? Short-acting breakthroughs only until what? Yeah, so once we establish pain control and once his body gets used to it. So he needs to become tolerant to it before we really start doing those long actings on that ocean. Okay? What side effects could he experience? Some constipation, nausea, vomiting. CNS depression, love it. Really, I hate it, but yes, right? What else? Histamine, respiratory depression, right? Things that will kill you. We should probably counsel them on. Okay? Questions with opioid overview side effects? We are going to stop here. We will pick up tomorrow talking about precautions. Heart, anything that you have that you need to share with everyone, why they are nice and quiet?
I will be here today until about 4 or 4:30 if you guys have questions. And I might come up during lunch if you're in here to just tell you some of the repeated questions that I've been getting to kind of direct you a little bit better. So if you're in here during lunch, I will just come, not like a review because you guys have the slide deck, but telling you like, hey, got a lot of questions about this, don't worry about that kind of thing as we go through on lunch. It'll probably be like 10 minutes. I'll be up here by the time you're done with class. That's all.